Okay, and welcome back from our break. I'm going to go ahead and turn to Dr. Walter Lynn for the next session.
Thank you, Lee. I'm Dr. Walter Lynn, a PTAC committee member. At this time, I am excited to welcome our panelists for our final session of the day. Four amazing experts will share their perspectives on payment models and benefit design improvements to enhance patient empowerment. You can find their full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. At this time, I ask our session participants to go ahead and turn on your video if you haven't already. After all four experts have presented, our committee members will have plenty of time to ask questions. First up, we are happy to welcome Mr. Robby Knight, who is the co-founder and chief executive officer of Soda Health. Robby, welcome.
Hi, thank you for having me. Awesome. Well, thank you guys for taking the time for me to share today a little bit more about what we do here at Soda Health and the opportunity ahead. Soda Health is a technology company focused on reimagining government benefits to work for everybody. We do that by administering what we call our smart cards that restrict purchases down to the SKU level, primarily working with Medicare and Medicaid plans to administer benefits for those recipients. What we do is we send cards to members, and then those benefits again are restricted down to the individual SKU level, whether it's things like transportation, bill pay, utility assistance, or certainly things like OTC and food kind of benefits as well here. We've been operating for a little over about 5 years now and have best-in-class technology to provide that SKU level restriction technology here. So that's a little bit at a high level. I think if you go to the next slide, one of the things that makes us quite unique in this space is our view in the marketplace as sort of what these benefits should be and deserve to be versus what they are today. Today, what you'll see is there's about $20 billion of spend roughly in this category today for supplemental benefits for Medicare Advantage. And our view is that these benefits should be viewed as medical benefits, as they are included medical loss ratio, versus being viewed as a marketing cost, which is today primarily what they're actually viewed today. And so our perspective here is that when we evaluate these opportunities, we should be closely partnering more with providers. And in this case, what you'll see here is an example of how we do precisely that to reduce the overall cost of care. And so overall, we send beneficiaries cards in the mail. They engage with us digitally with our app, with our call center, and also with text messages. We encourage members to get care gap closures, whether it's an A1C, HRAs, or other kinds of clinical measures performed at their local pharmacy that we have integrations with at the point of service. And then we make it really easy for patients to understand what care they're eligible for and how to do things that really drive overall improvements there. What I'll say here at a high level is that to date, we have some pretty remarkable engagement rates to date. We have a pilot with a national Medicaid plan. Over the first 6 weeks, we have over a 60% or almost a 60% completion rate of A1Cs. Again, taking this sort of modal approach of not just engaging them with a reward or incentive, but also engaging the provider, in this case, the pharmacist. So that's a little bit about what we do here at Soda Health. And then you can see on the next slide here some of the patient experience pieces here. The last point that I'd make here is that we're dealing with beneficiaries that have a lot of things going on in their lives, so we need to make it really simple. And as I think about the benefits that we're offering here to our beneficiaries, our view is to make this a really streamlined experience to help them understand what's in, what's out, and how do you really drive value for everybody. And so for context, typically members call, this is actually one of the top reasons that members call their health plan to see what benefits are in, did the card work or not. On average, about 30 to 40% of calls that health plans receive are about these kinds of benefits. For us, about 2.5% based on the member experience that we've built out. So that's a little bit about us, and happy to share more on any questions, but thank you for your time.
Thank you, Robby. We are saving all questions from the committee until the end of all presentations. Next, we are excited to welcome Dr. Clay Johnston, who is the co-founder and chief medical officer of Harbor Health. Please go ahead, Clay.
Thank you very much. I'm going to just talk about aligning member incentives as well from the perspective of a payvider. Next slide. So my own personal journey, I'm a stroke neurologist. I kind of rose up through the research ranks, frustrated with how little we knew at UCSF, then came to the realization that it was really the healthcare system that was preventing us from being as innovative as we should be in focusing on the key problems. And so left to start the Dell Medical School at UT Austin. This is now 11 years ago. And what we did was we took individual conditions and we rebuilt them. And using human-centered design approaches and technologies, and really ignoring fee-for-service and focusing on how can we improve outcomes, improve experience, and reduce cost. And that was largely successful for a whole bunch of different conditions. We could save quite a bit. Musculoskeletal costs anywhere from 30 to 80% less, but also for bipolar disorder, or breast cancer, a variety of things. But the problem with that model was we couldn't get paid differently. So we even bundled payments around conditions was just a huge lift with all the payers. There was only actually one insurer that saw what we were doing, was excited about it, leaned in. It was called Bind. It's now become Surest. And the problem was they actually didn't make it into Texas in time for me to get frustrated with the fact that wasn't going to solve our problems. So I left. And actually, the CEO of Bind sold that company to United, and so it became available. And so the two of us started Harbor Health. So he's Tony Miller, and he's the CEO of Harbor Health. So that's kind of my journey. So next, really what this is about is it's the money. This is meant to be animated, but it's fine. If you don't control the dollars, if you don't really have control of all aspects of those dollars, then you really can't design the ideal program underneath, particularly because all the incumbents that are controlling the dollars are strongly incented to keep the system where it is today. They've already optimized their systems to create maximum benefit and profit for themselves. And so if you don't control those dollars, you can't get it done. So really this was the driving notion about why we needed to be a payvider and control the insurance premium, whether we were the insurer or not. Next. So what did we try to do? So here we're starting in Austin. We'll grow from Austin to here, mostly around Texas, but really design around people, again, around health journeys, around conditions, because those are sensible to people, but also sensible to us and capable of redesigning. And then we use a whole variety of players. We don't just have to use a biller, so we can use coaches and other things, including technologies. And then we can smartly subsidize the things to get people to do the right thing. And it could be, health promotion type activities, but it also could just be who you go and see. And I'm going to kind of illustrate that really quickly. And then delivered in the communities that we live in, obviously. Next. It really is about surrounding the member with the things they need, and then also recognizing that many, many things around health, they don't occur in an office visit. And so how do you create a system that's really responsive to people in and outside office visits, and not just with people, but again, also with technologies. Next. And part of this too is flipping everything on its side. And I've mentioned this a couple of times already, but really organizing around condition. And all our data systems are built this way so that we can track conditions, condition outcomes. We can use that for prioritization, and we can use that to optimize care pathways for members. Next. One of the ways we do that is to figure out where people should go. We're not trying to own everything. So as opposed to Kaiser, we're not going to try to own all the specialists. We're not going to even try to own hospitals. That makes it more feasible to do what we're doing, which is already extremely difficult. And so one of the things we have to understand is where we should send people. So this is an example from real data from a local HCA hospital system. Health Grades is online. It's what our members see. It's actually what most physicians feel. People like it when they go to see that person. So then what else can we know? Next slide. And the reality is we have a ton of information. Next slide. That tells us more about the quality of their work. There are a variety of different ways that we can sense and determine quality. For us, we just ingested a ton of claims data, all that we could get. So 60% of commercial claims, 100% of Medicare data over multiple years across Texas. And then we can also look at average cost, not just for their pro fee piece, but the whole thing, the whole arc of care for specific conditions, for specific procedures. So this is an example for a specific procedure. Huge differences in costs for these providers, small difference in quality. Obviously, why would you send somebody to somebody that costs, 2.5 times more? Next slide. And in fact, there's a whole range of quality and cost for providers, and they're not associated. You don't, obviously, the point that higher quality doesn't mean higher cost. In fact, often it's the opposite. And so next slide. So what we can do is start to subsidize good decisions. So then take those providers that we identify as being, this is different from a narrow network. We're allowing people to go anywhere, but we're saying if you go to these folks, there's no copay associated with your making that trip. So this is an example of how the benefits then align with our care model that aligns with eliminating waste and then developing partnerships with these folks to focus even on enhancing quality further and also in coordination. Next. And then what that looks like, it doesn't have to be just on referral. It can be on any point in the care pathway. And again, having them sensible along these care pathways and conditions makes this doable. And so then, timing of things, what's right for you at this time, those kinds of things can then become things that are encouraged by eliminating copays associated with them. Next. We're not alone in this. I mean, that's obviously the case, but a couple other examples in Texas that are doing aspects of what we're doing. One is curative. They basically just say you get an initial onboarding visit. That's really important to understand, your benefits and how they work and where you should go, and also plug into primary care. And if you do that, there's zero deductible for everything downstream. Another is Everly, and it's a company that uses rewards cards to incent good behavior. So obviously, these are just a couple of other examples to throw them out. I know there are many others, but I didn't want to pretend like ours was the only one out there. Next. That's it for me.
Thank you, Clay. Next, we are pleased to welcome Dr. Paul Berggreen, who serves as the Chief Strategy Officer of GI Alliance and is the founder and president of Arizona Digestive Health. Welcome, Paul.
Thank you. Good morning. So yes, I'm Paul Berggreen. I am a gastroenterologist in Phoenix and also Chief Strategy Officer of Specialty Alliance. Next slide, please. I wanted to talk a little bit today about how this ecosystem would work, not only from the patient's standpoint, but from a practice standpoint. And I'm going to start off with my favorite slide here. It's not just designing a payment model, it's how do we improve the clinical value that we are delivering to populations of patients. So in the center is a population of patients in the blue, surrounded by the typical care that we deliver, whether it's an office visit, a procedure, et cetera. Very traditional, but when you wrap other services around that, I'm going to start off at the 1 o'clock position with our physician leaders throughout the entire GI Alliance. And by the way, it's a very large group. We have just under 1,600 physicians, GI and urology right now. So we have a lot of experts. Those providers have developed care pathways in all of our relevant disease states. And those care pathways then lend themselves to development of a population health dashboard. That dashboard is vital for us because it enables quality improvement projects, and quality improvement projects then transition naturally to a population health management system throughout the entire corporate organization. The dashboard has some nice corollary benefits as well. It can serve as a research patient finder tool. It enables real-world evidence data projects, which are very valuable for a practice to shape direction of the practice and the care. Importantly, it powers our chronic care management program. We're currently managing about 50,000 patients every month in our program around the country, and that includes remote patient monitoring. And interestingly, that also enables services to be delivered to our patients that typically are not covered by Medicare or commercial insurances, and that includes nutrition counseling, which is vital for us, behavioral health, pharmacy tech services for patients with polypharmacy, really vital services to deliver to a patient. Once you've wrapped all of those services around your ecosystem, then you can confidently engage in a strategy of a value-based contract. But it also works well in a fee-for-service world. Next slide, please. I want to show you the dashboard. So this actually is a dashboard, and this says we're at a total of 2 million patients. This is an old slide. We're actually aggregating data nightly from 5 million patients. We've done this for GI and urology. We divided this into our disease states, and everything you see on this page is a filter. If you can go to the next slide, please. I'm going to use IBD as the poster child for the next level of information here. These are more granular filters for inflammatory bowel disease, and it allows us to actually start to slice and dice our patient populations to get granular information down to the individual physician, the individual office, the individual patient population. So this is really key to what powers our program. Next slide, please. Importantly, this is what we were particularly interested in, right? These are metrics that were pulled from our care pathways to look at this disease state. We have others for in other disease states. And we measure performance of our patients and our physicians based on these metrics across 5 million patients. We therefore, in inflammatory bowel disease, first time ever, we were able to actually set a national baseline of how good our physicians are at getting our patients to be adherent with their care plans, which we know correlates to better outcomes and lower overall cost for the system. So this is key. Next slide, please. The results of this is in the 121 offices that we measured with this dashboard, the 6 that you see in the boxes here were the pilot programs. And we were able to dramatically improve their patients' adherence scores with a focused effort over 6 months in 6 locations. And that actually has now been expanded. This was just in April. We've now expanded this to 24 locations. We're adding at least 4 locations every month. So it's a pretty rapid rollout of this program. Next slide, please. What you see importantly is that in that 6 months, in that 6 locations, we identified over 900 patients that had fallen out of adherence with their care plans. And on the right, what you see is that we were able to capture just under half of those with this concerted effort. And that yielded additional labs, additional office visits, additional procedures in some situations, and very importantly, over on the left side of that, changes in medications, particularly the biologics. As you know, some of these biologics are extraordinarily expensive and need to be used very carefully and very appropriately. This helped us to identify those patients who either were not responding and needed to be switched, or who would have benefited from a biologic and were not on one. So this is really key to population management. Next slide, please. So really, when you design a program, I would say that you have to have better information, and you have to put together models that start with the patient, but focus on the practice, because the practice is the one is the entity that's going to be delivering that care. If you've got better information, then you can make sure that everyone in this ecosystem wins with that information. But again, keep in mind that this system has to work in 2 worlds. It has to work in a risk-based world. It has to work in a fee-for-service world, because that's where our patients are going to live, in both of those worlds. This model actually enables that. So I'll stop there and say thanks.
Thank you, Paul. Finally, we are glad to welcome Ms. Kaitlyn Pauly, who is the Chief Integration Officer for the American College of Lifestyle Medicine. Kaitlyn, please go ahead.
Thank you. Great presentation so far. I'm Kaitlyn Pauly. I serve as the Chief Integration Officer for the American College of Lifestyle Medicine, and today I've been asked to present on payment innovation and benefit design for patient empowerment. Next slide. So we're all likely too familiar with the unsustainable epidemic of chronic diseases in America. We know that 90% of healthcare costs are tied to chronic diseases, and that 80% of these diseases are driven by lifestyle factors. Next slide. Our healthcare system should be designed to address root causes of disease instead of only managing symptoms. The reality is that lifestyle-related chronic conditions are not properly addressed in medical and health professional education. And because of our fragmented one-to-one episodic short visit approaches to care delivery, there's often not enough time or resources to properly address lifestyle in clinical care settings. The focus remains on disease and symptom management instead of root cause treatment. This is reinforced by lack of sustainable payment and reward systems to address lifestyle-related root causes. There are even misalignments that unintentionally penalize health restoration, disease remission, and medication de-escalation. Next slide. This is part of why the American College of Lifestyle Medicine was founded in 2004, to educate and equip clinicians on how to treat root causes of chronic disease and to advocate for changes in the current healthcare ecosystem, to support clinicians to deliver and patients to receive lifestyle interventions. Lifestyle medicine is a medical specialty that treats root causes with therapeutic lifestyle interventions, allowing clinicians to restore patients' health and reignite their joy in practice. Sick care manages symptoms while root cause care restores health. Next slide. And for those who haven't heard of lifestyle medicine, it is a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat, potentially reverse, and prevent chronic diseases such as cardiovascular disease, obesity, and type 2 diabetes. Next slide. The lifestyle medicine 6-pillar framework includes optimal nutrition, physical activity, stress management, restorative sleep, avoidance of risky substances, and connectedness. Imagine a world where clinical care teams can support and guide their patients towards structured, evidence-based lifestyle interventions, either as a first treatment option or as an adjunct treatment for medications or surgical procedures to truly address the root causes of disease and optimize health outcomes. Not only is lifestyle medicine a way of bringing full informed consent of all treatment options into healthcare, it also empowers patients to engage in their own health journeys. Next slide. The lifestyle medicine framework and care delivery approach is evidence-based. Clinical practice guidelines for most chronic diseases list lifestyle change as a first treatment recommendation and as an effective adjunct for most pharmaceutical and surgical interventions. Next slide. And research now shows that the same lifestyle factors that cause chronic conditions can also be used intensively to put diseases into remission, de-escalate, and even discontinue medications. Our nearly 15,000 members are achieving these types of outcomes daily, and they need support to sustainably scale their success. Next slide. So the vision is for benefit design that enables patients' awareness, empowerment, and control of health, where trained clinical care teams can lead and support care delivery that reinforces lifestyle changes to prevent, treat, and remit chronic conditions. Next slide. Some ideas for benefit design that might help in this cultural shift toward patient empowerment include expanding coverage for therapeutic and intensive therapeutic lifestyle interventions delivered by trained clinical care teams, eliminated or limited cost sharing for high-value lifestyle services that address root cause, prevention, treatment, and remission of chronic conditions, coverage for evidence-based lifestyle intervention beyond clinic walls where people live and work, coverage for engagement with all qualified team members who deliver evidence-based lifestyle intervention. And I think we already heard today that many of the services that clinicians offer, like dietitians offer, are not available for coverage right now. Coverage for tools that allow for asynchronous follow-up to support health behavior change and engagement. And then coverage for services that address barriers to applying lifestyle change, like nutritious food access and supervised exercise therapy. And then, of course, removal of one-time beneficiary rules for lifestyle interventions that currently do exist. Next slide. For this, we also need aligned payment incentives and quality measures that reward evidence-based root cause treatment, along with removal of penalties and barriers for providers that are using these approaches. So 2 quick examples of penalties include when clinicians can support health restoration of their patients through lifestyle-only intervention, they may get dinged on some medication adherence quality measures. And with risk scoring and value-based arrangements, when a clinician can support a patient into disease remission, their risk score goes down and the payment for the clinician also goes down. So payment should really support and reward clinicians for offering evidence-based lifestyle interventions that engage and empower their patients to take control of their own health. Next slide. So similar to benefit design, some ideas for payment innovation that could help support this patient empowerment include compensating fairly for those therapeutic and intensive therapeutic lifestyle interventions that are delivered by trained clinicians, offering hybrid payment models to cover multimodal interprofessional care team delivery of lifestyle interventions, offering proper payment and clarity for delivery of group visits, also known as shared medical appointments that can scale the treatment options, expand the digital and asynchronous tool care coverage, which really helps people understand how they can control their own health behaviors, expanded options to address upstream drivers of health, offering incentives and rewards, not penalties, for disease remission, health restoration, medication de-escalation, and patient engagement, and then use metrics like lifestyle improvement, patient activation, quality of life, health improvement, health outcomes, disease remission, medication reduction, to measure progress, incent and reward clinicians who are delivering these amazing interventions and outcomes. The great news is that we're now seeing requests for information about payment that supports lifestyle interventions like nutrition, social support, and physical activity, and quality measures for nutrition and well-being. Next slide. If you feel that evidence-based structured lifestyle interventions should be available to patients and that clinicians should be able to sustainably deliver lifestyle interventions, there are a few things that could help. Supporting physician-led interprofessional pilot programs to test hybrid payment models that align with lifestyle behavior change guidelines, removing structural and systemic barriers that address the payment and quality measure misalignments that I mentioned today, collaborating with stakeholders across the healthcare ecosystem to co-design benefits that empower patients and reward clinicians. And while today's time was really spent on healthcare's role in patient empowerment, healthcare alone cannot tackle America's chronic disease crisis. I'm sure that you can all agree that stakeholders across America should take ownership in moving our population toward making healthier choices easier for all Americans. Thank you for your time and attention today. I'll look forward to taking questions.
Thank you, Kaitlyn. And thank you to all our experts for those great presentations. Now we will open the discussion to our committee members. At this time, PTAC members, please flip your name tent up, or for our virtual committee members, please raise your hand in Zoom if you have questions for our guests. In the interest of ensuring balance across different perspectives and questions, we encourage experts to keep each response to a few minutes. I'm going to go ahead and start with Krishna.
Thanks, Walter. Thanks, Dean. Great job presenting. Yeah, I loved hearing your perspectives. Curious on, you all know sort of value for the Medicare Trust Fund, beneficiaries is a topic that's very important broadly as a nation. Curious if you can share your perspectives on just like return on investments, or any of the sort of levers you were all speaking about. Just, are you seeing early outcome improvements, whether it's financial, non-financial? That would be helpful for us to learn more about.
I'll go first. So the question is, are we delivering value? And the answer is, you can deliver value in any payment model that you come up with. I think the more relevant goal for the physician practice is to deliver better outcomes for the patient, to change some of the dynamics that lead to poor outcomes. In some situations, that's something that we can prevent, in some it's not. But the fact that there's gaps in care, that patients are falling through the cracks, that things are simply not getting done because of the limitations of the systems in which we're operating, doesn't seem to be something that we should tolerate. And so, what I've designed is a way to recapture that and deliver that value in the form of better outcomes in whatever type of payment model that you're engaged in. I'd be interested to hear others' opinions on that.
Yeah, I guess for us, so we participate in as many of those programs as we can, the ones that are trying to stimulate innovation and a focus on value. And I agree with Paul that it starts with actually doing a good job, knowing that you're doing a good job. But the reality is those programs have been disappointing for a couple of reasons. I think one actually relates to what Kaitlyn was talking about. They're annual programs, right? So the rewards are all based on annual performance. A lot of lifestyle interventions actually don't accrue in the year in which they're provided. And so that's a fundamental flaw of those programs. Why invest? If I'm taking the risk, I own all the costs. Why invest in something that's not going to pay off in that year, particularly with all the transfer between plans that occurs. This isn't unique to Medicare. This is true also in commercial as well, but it is a fundamental problem. For Paul's profession, it's partially been solved by saying, something like a colonoscopy is outside that, and we want that done, and it becomes a quality metric. Colonoscopy is an example of another thing that if you're an insurer just focused on that given year, you'd rather that happen next year or the year before, not the year that you insured that patient. So, there are kind of workarounds for some aspects, but they've been unsuccessful. But I think even more important, success in those programs, whether it's Medicare Advantage or whether it's ACO REACH, or really all of the programs, are more based on risk coding than they are on actually achieving better outcomes for patients, and reduced spend, particularly reduced spend for waste. So I think how do you get around that problem? That is an extremely difficult problem, but that's partly what's driven us to say we have to be our own insurer. Because if we're not, then we're just subjugated to someone else's rules, and then we have to spend more energy in risk coding than actually taking better care of people. And if we don't, which is the way we started, where it's like, we're not going to do that. That doesn't help the member, and it doesn't help society for us to focus on risk coding. The problem with that is everybody else is working on risk coding. And so then the benchmark dramatically impacts us. And so then we have to achieve, 10%, 20% delta in performance just to get to the risk coding advantages that others who have focused on that have been able to achieve. So those are, I think, some of I love the attempts. It's the right direction. It's given us an opportunity to do some great innovation, but I think we really do have to think about how the program can mature and do what we'd like it to do.
Thank you for those responses. I'm going to go to Chinny next.
Thank you. My question is regarding design improvements. I'd love to direct it to Robby, Kaitlyn, and then Dr. Johnston and Berggreen as well. So what design improvements are important to make for supplemental benefits to drive real value to the system, and think also through the lens of waivers that can be put on the current environment?
Yeah, I appreciate the question, Jenny. As I think about how we got here for supplemental benefits, it's been a pretty interesting ride in general over the last several years. 2019, the average benefit value for supplemental benefits was about $155 per member per year. Last year, it was roughly $1,500 per member per beneficiary per year, if you exclude a few of the benefits there. In addition to having a 10x increase in benefit value over 5 years, utilization has also doubled. So what that math equates to is roughly a 20x increase in overall cost for health plans that are having to choose between funding cancer care and funding over-the-counter vitamins. And so the real question here is what kind of model needs to exist, and let's be honest about what exists today and what really should exist. As I think about today, these benefits come out of medical loss ratio spend, so claims dollars. But today, what's happening is health plans are using these dollars or these benefits to really drive more membership acquisition. So it's a cost of acquisition for marketing for them. It's not intended primarily to be an overall value driver for them to really be a tool in their toolkit to drive tangible, real ROI when it comes to cost of care improvements. And to be clear, I say that as a benefits administrator in this space. I think the question becomes on value and what you can do to drive real outcomes and tangible ROI. I think you have to create a model where the provider is actually the center of that, right? And today that's not the case. Today you have benefit plan design that is done on the front side, and in many cases, these at-risk providers are actually eating some of the cost of it. As I think about things with some of the things that we're doing here in general, when it comes to overall engagement for beneficiaries, we're seeing a remarkable amount of engagement on a per member per month basis. And so think about digital health in general, engagement is typically about 4 to 5% once per year. We're seeing over 70% monthly active users. That is consumer grade engagement. And so my perspective here is, why don't you take that and identify what other challenges exist in that member's life and then really drive overall cost of care improvements. And my position here is that you do that by putting the physician in the center, by creating some parameters in place that says, if you have these conditions or these sort of overall challenges, here's the things that physicians or pharmacists can prescribe in terms of interventions to really drive ROI and value. We've already started with that. We're doing a national plan, national pilot with a large payer. And again, we're seeing almost 60% of those people that we require to get A1Cs to be, a stage gate, if you will, to get additional benefits. And it's happening, right? So again, my ask here of the group is if these are truly MLR dollars, if they're truly claimed spend that's going into it, I think we need to refocus the industry and the market around what truly is value and what other players that are in the ecosystem that are getting this outsized value, i.e. retailers, others, and say, how can we help them to support us with this challenge? Because as Chris Clump mentioned, who's the head of Medicare, we have roughly, and my numbers might be a little off here, but Medicare Advantage contributes roughly about $2.2 billion in savings. That sounds great until you realize it's on roughly about a 1.7 trillion of spend. So if any one of us really owned that business, we'd say this math isn't working. So we really need to redesign what actually does work to really drive ROI and true value here. So thank you.
And in terms of benefits design or design in general, I think a lot about the care delivery. And I think we've established today that you cannot have value-based care without high value or value-based payment without high value care. And thinking about how do we redesign the care that we're offering to patients. And I think patients are really in a place where they want to have high value engaged care with their clinical care teams. We see this for our clinicians in our network. They are excited about the ability to have a lifestyle medicine provider who's focused on the upstream drivers of care and their lifestyle and empowerment. I'll pass the baton to someone else. I don't think I quite answered that question.
Yeah, and just to pick it up, I think Robby's response is right on. I think those supplemental benefits or additional benefits are really used as a marketing tool, but even more, they're to market to the right kind of person. And so, like even the ones I was showing in the commercial marketplace for Everly, they're really to attract healthy people into the plan. And then of course they'll get coded up so that, they look sicker than they are, which then contributes to our belief that there's cost savings. But that's really what they're used for. I think it should be, and just as you said, Robby, I think there is evidence base for a lot of interventions that are in that space, including all the ones that Kaitlyn was talking about. Those are the kinds of things that should actually be supported and wrapped into it, where the benefit really is a healthier person, not a freebie. And so, yeah, I'd love to see that evolution to support things that are really align with an evidence base. I would also say one of the major challenges we have is member engagement. And again, I love that, Robby, you get that member engagement is so critical. It's hard to get members to do what is in their best interest. And so too, if we can start to think about those benefits as enhancing member engagement, that is an awesome goal that everyone would benefit from.
Yeah, I'll just all great points. I'll just add this from a practice standpoint, right? Because the practice is the ones who are actually caring for the patients and responsible for the outcomes. If you don't have a system in your practice that enables you to globally care for those populations of patients and affect their outcomes at scale, then you really have no ability to change the dynamic, right? To deliver better value at scale. And I will tell you something else, that when you think about this, remember that whatever plan that we're having designed for us, maybe in Medicare, maybe it's a commercial insurer, we can't segment the care we deliver to our patients based on a plan design. We're going to deliver the best quality care that we can to every patient in our practice. So whatever we come up with has to be in the best interest of our entire practice, not a segment of patients. And so that's more challenging because we really have to keep our eye on the big ball here rather than a small segment of that ball. And when we're building these programs in a practice, they're very difficult to build. They're very expensive to build, and they're very expensive to maintain. So there's got to be some benefit to the practice as well. And quite honestly, a risk-based model in specialty care, the adoption around the country has been pretty underwhelming. And in my specialty, it's been non-existent. Even though we can do it and we're ready for it, they're just not there. So we're proceeding in both worlds, right? Fee for service and ready for risk.
Thank you for those responses. Larry.
Again, a great session. Thank you to all the speakers. You guys have all reaffirmed for us the reason this committee exists is that we're supposed to be focused on what the provider space needs in building value-based care solutions. And I'm struck with the comment that Paul has said a couple of times here today, focus on the practice. And we need to focus on the business model of the practice, and that our move to value-based care is sensitive to that. And Clay touched on a couple of topics that prompted me to think of questions that I'd like to use to just emphasize the situation. The first one has to do with risk. And obviously, Clay, you've been in the same situation I've been in over the last few years, where you generate savings, you're very proud of your savings, and those savings get denigrated when there's a risk adjustment put on by the plan. And it is costly to have our providers code in the necessary way for us to generate the risk assessments. And there is no extra reimbursement to a practice to focus on this coding. So I think my first question, and I have another one to follow, but my first question is, what have the four of you done in your practices to promote more accurate coding so that you're ready for risk-based contracts and that you don't lose your shared savings from poor coding?
Yeah, so we've had to do this extensively, and again, in the beginning, I wouldn't say ignored it. We knew it was an issue, but we chose to focus on the improving outcomes and lowering costs, reducing waste in care. And it was only when we realized what a hardship that was creating for ourselves that we recognized that we needed to actually shift direction. So what we do now, and now it's really hard to catch up, right? Because it's over multiple years. For example, for ACO REACH and their prior year, it takes years to catch up. The ACO REACH only allows you a small 3% increase in a RAF score in any given year. Lots of issues like that. So we use first of all, educating people about the importance of the coding and why we have to care about it. That's frustrating too, because it's like, wait, we told you could be the kind of doctor with integrity that we said. We don't believe in over coding. We just believe in coding to the level that's appropriate, and that's the other key thing. And then IT systems that flag, prior year. HCC codes that could be reused in a given year, as an example, or that create opportunities based on a review of what's in the record. And so we use those feed up recommendations at the time of visit, and then those are responded to. So those are examples of things that we put in place.
Yeah, I'll go next. And hey, Larry, good to see you.
Nice to see you.
So let me just give you a perspective from a private practice standpoint. Of course, we have a very robust compliance department. We have people that do nothing but validate coding and make sure that we're very compliant, and that's a big deal for us. But not because we're in risk-based models, simply because we want to be compliant and code correctly. In private practice, then you deal with commercial insurers, and as many on this panel know, I mean, in the last few weeks, the Cigna and Aetna policies of automatically downcoding level 4 and 5 visits. That's what private practice is dealing with right now. So our heads are spinning because of the pressures that we're facing from all sides of the ecosystem right now. And while we have an entire department to make sure that we're coding correctly, our priority is making sure that we're being paid appropriately in a fee-for-service model. So whatever is formulated from a risk-based plan, correct coding is not really a problem for us. The problem is that we have a mixed constituency of payers, and we're having to deal with threats from that. Just my take.
Others?
I just I don't own a practice, represent clinicians who own practices across the country, and the biggest thing we hear about the risk scoring that becomes a challenge for people who really focus on delivering better health outcomes is that they get paid less once they do that. So there's no incentive for having a healthier patient population in a risk-based model with the current coding the way it is.
So it's not only cumbersome to code correctly, it can interfere with your payment.
Correct.
Yeah. I don't want to. Robby, did you have a comment? No. Okay.
No comment on my side.
Okay. So my second question has to do with another thing Clay brought up, and that is the copay issue. And we heard in a previous session today that it makes no sense that when you want people with preventative, proactive care to be paying copays, because an $8 copay can kill the utilization of those. And I think Paul mentioned chronic care management, and Clay, you mentioned that as well. And so, what strides have you made with your payers to minimize that copay issue for the patients when you're proactively billing for a service to provide chronic care management?
Yeah, that's a great question. We've worked hard on this as well. And again, this is one part of our rationale for having our own insurance, right? I mean, the way we treat copays is just like hit people on the head, quit spending in healthcare. We're going to take some money out of your pocket whenever you do. And that's obviously dumb. You want to use the copay to encourage the right behaviors. And sometimes you're getting too little of a behavior. And so to encourage it, you might even want the copay to be negative, right? To actually subsidize somebody doing something that's in their best interest. We can do that, obviously, with our own insurance. The other insurers have been really inflexible in terms of how they've thought about it. So for ACO REACH, we have petitioned to get copays removed for certain activities that we provide, and they'll do that. So they'll, let us say, okay, no copay for CCM. We don't need to collect for that, and so we can bring people into it. For the MA plans, they haven't accepted that from us. I think that in all of those plans, it's a shared risk arrangement, right? So they, if there's savings associated with the care that we're delivering, they're pocketing half of it on average in those plans, and they're paying 100% of what we bill. And so I think they still see it as a potential grab. That I think is extremely short-sighted. We know those kinds of programs work, and they really should be fully supported in those plans. A good example of something that actually could be a shift. It could be that MA plans are required to provide CCM coverage without copay. That would be an awesome thing that would drive the right behavior and response from practices as well.
Yeah, Clay, I agree with you. The chronic care management program has actually been very beneficial, and it's been a good idea. What we saw, and the cost is modest, right? The copay for those patients can be as little as $8 a month. And they don't necessarily get that cost every month. But during the public health emergency, copays were able to be waived, and we did, and we had remarkable enrollment in our chronic care management program. And as soon as the public health emergency was over, enrollment plummeted.
Yeah.
And it's built back up, but it's been years to build that back up. So that seems like a sort of almost a no-brainer, is that why would we be charging such nominal fee for a service that provides so much value and is such low-cost service? The other very frustrating thing is that some of the commercial payers still don't cover chronic care management services, and Cigna is one of them nationally. The Blues give us nothing but trouble about chronic care management services, and so that seems to be counterproductive. They're trying to deliver quality and a longitudinal care to their patient populations. They have a very low cost, high effective service that does that, and yet they're putting up payment barriers. And that one I don't get.
One of the things that the way we think about it is probably a little different is as we think about chronic care management, I think about a lot in the lens in terms of the pharmacist and sort of the most optimal side of care, if you will. I think about bundled payments or other kinds of different interesting payment models that could exist. My view is you got to generate savings to then reinvest in other places. And so certainly not a fan of the copays for all the reasons that you folks here all talked about. I think our approach to date has been to work with health plans to say, like, here's an overall pool of dollars that we need to be able to manage for you, right? And if you think about individual HEDIS measures, let's talk about that, right? So individual HEDIS measure CO6, medication review, medication reconciliation, the average cost for CMS today is about $124. In retail pharmacy, it's literally half that. And so my view is here is that if you want to really drive value and outcomes here, shift it to the side of care that's most efficient to then generate the savings that you can then reinvest in driving real outcomes here. Now, the challenge with that is you need to be able to provide better information and data back to the PCP that you have in place there. But I guess my comment here more globally is there's got, like, again, it's 2.2 billion in savings, whatever the number is, on 1.7 trillion in spend. There's got to be ways to generate that savings to then reinvest, because what we're doing today isn't working. And from a cost profile, there's sort of a different model here. In my perspective, again, given our work with over 50,000 pharmacy locations in the U.S., is that you should optimize the side of care to then generate those dollars that you can then reinvest.
And while chronic care management is a great model that a lot of our clinicians are using, many of them are also delivering intensive and therapeutic lifestyle change programs in shared medical appointments or group medical visits. And the copay has been a barrier for our clinicians, especially for the patients who can't afford to pay multiple copays over the course of weeks or months if there's a series of visits that's focusing on their chronic disease. So that has been definitely the experience, and it causes attrition over time. So patients may just be engaged in the first few visits, and then over time, if they have multiple copays, decide they can't afford it anymore. So.
Thank you all. But it looks like maybe we have a waiver option here to fight for. Thanks.
Are there any other questions from my fellow PTAC committee members? Jenny?
This is maybe a little bit more specific for building on Krishna's question earlier today. When you look at the various lifestyle changes that we've seen and the various sort of supplemental benefits, what would you point at that has the largest ROI in terms of pure just spend management? So I'll throw it out there.
I'll take that one here first. Definitely food and transportation. The number one barrier we have for beneficiaries and members being able to get to these appointments, to whether it's dietitians that we provide support for, or A1C for pharmacist interventions, is absolutely transportation. And so that's the first one. In terms of overall ROI and outcomes, certainly food. The literature is pretty substantial out there in terms of the impact that SNAP has had on overall driving cost of care improvements. I mean, it's great that you want to drive care and outcomes, but the reality is, in order to first do something that's important, for a patient, you have to first serve their first order needs and do what's important to a patient. And if you can't get to the doctor, you can't get to the grocery store, you can't even eat, you're having to choose between cutting pills in half and, making, eating for that week, that's a very foundational problem to solve for. And so I think what we've seen is food has the best interventions. What I'll also say is part of that challenge, though, is that there's a complete lack of coordination between CMS and Department of Agriculture that I think is changing now around whether it's EBT dollars, so WIC, SNAP, TANF, all those dollars there, and then other supplemental benefits that you need to have to provide a more holistic coordination of care there to really drive value. But for what we've seen in general here, certainly ROI is much more pronounced in things like transportation and food benefits.
I'd agree with Robby in terms of the food and nutrition as seeing the most substantial cost benefits. And with intensive therapeutic lifestyle change, nutrition is absolutely the number one way that patients can achieve disease remission and improvements in health outcomes. And, if a disease goes into remission, the cost for care goes down longitudinally. So, but also wraparound care is necessary. Like if we think about medical tailored meals and produce prescription programs, those can be really great acute interventions to offer patients. But if they don't have the ability to maintain nutritious dietary patterns following the intervention, they may wind right back in the same place. So like patient education, nutrition education, culinary education, and then healthy food access are all really important for achieving those long-term outcomes for food interventions.
Yeah, nothing really to add. I agree completely. It's, nutrition and the transportation issue is really important for some as well.
Yeah, I'm going to just say maybe just a little bit more global of a view. I think it's compliance with a treatment plan and identifying the barriers to that. Right. And Robby was saying it, sometimes it's transportation, sometimes it's dollars, sometimes life gets in the way. So a system for the practice to help to take some responsibility for helping the patient to be compliant with the plans that the physician has outlined, it seems to me to be sort of part of the solution.
Thanks for those responses. I wanted to circle around to a comment that Paul made earlier, that the practice takes care of the patient and the practice is responsible for outcomes. This session is largely around empowering and enhancing patients in their own care journey. And I'm wondering if any of you have thought much about making the patient in part responsible for their outcomes? If so, in what way? And secondly, what kind of performance measures have you thought about in terms of effectively measuring patient empowerment and patient engagement?
Yeah, so I mean, I'll just tell you how we've been thinking about this, because I think that's a great question, and it's like, yes, the patient is responsible for how healthy they are. And ignoring that ignores their critical role to anything working. For us, though, of course, their outcomes are determined by their actions, by our actions, and by chance. Nothing that I'm doing today will help me prevent inflammatory bowel disease that we know of. I mean, Paul could probably tell me that's not quite right, the amount of fiber, that kind of thing. But whether I get that or not is largely a chance. And so we don't want to penalize somebody for having bad luck. So for us, it is how do we engage our members? Again, we try not to call them patients because they don't want to be patients. How do we engage our members in taking the right steps in their care? And then for us, the tool that we use is the copay. So because now there's an expectation that you're having to pay for your healthcare. So that effectively is creating a subsidization for them to do the right thing. Then, of course, it's back on us in clearly defining what those right things are, right? So that we can create a structure in which those benefits can can accrue to someone if they do the right thing. In that structure too, there's a right thing for a clinician, and that's different from an RVU system, right? And so we're at the same time creating that incentive structure for clinicians. And that's also a new challenge, replacing the RVU with, did you do the right thing in order to achieve a better health outcome or reduce waste for this member? And so we're kind of building those systems in parallel. Being the payvider allows us to do that, right? Because if we weren't the provider, we wouldn't, we wouldn't have control of, clinicians and clinician behavior and all those things. And if we weren't the payer, we wouldn't have control of the benefits. So that's like one of the real nice things about being in the position that we're in.
Yeah,
I'm sorry, go ahead, Robby.
So one of the things that, thank you, one of the things that Paul mentioned I really like is thinking about really focusing on the treatment plan here. As I think about putting the patient, the member at the center of their own care, part of the opportunity here for us in general here is to realign what kind of benefits or challenges that realign benefits and solutions for that individual patient. And so today, for example, everyone gets an OTC benefit and they get quite a lot of dollars for that benefit, increasingly less, but still quite a lot of dollars. Back in my prior life, what I saw when I was at Walmart was members that would only have an OTC benefit, that would go buy something and then just sell it on eBay because they had these dollars, they had a finite amount of fixed income dollars they were trying to spend, and they're trying to make ends meet. Because the reality is they only need so much in vitamins. And so to Paul's point, I think part of the really interesting value here in terms of thinking about a more holistic view of keeping members at the center, right, is making those benefits or those kinds of programs dependent on what the individual member and that provider actually think is the best treatment of action for that member's overall care, right? So true personalized benefits based on individual need. That's where I had hoped things were going with VBID, but instead it was used as a marketing vehicle to drive marketing costs versus actual ROI. I think the real value here to having the patient being at the center and a lot of these sort of and these interventions they need support with is to actually be able to have them help with that provider determine what's the best course of action, what they actually need to improve their overall health outcomes, and that be centered based on the treatment plan that they set alongside that physician. So thank you.
Yeah, the challenge that we have in identifying what leads to a good outcome versus a bad outcome is that for many of our diseases, and I'll use inflammatory bowel disease as a poster child, but we don't have those metrics. We have published guidelines to say, hey, this is what you should do in this situation, but measuring that across populations of patients or nationally is something that hasn't been done. We actually, as part of the dashboard that I showed you, what we were able to do with that was actually take those metrics that we identified from care pathways that were published and set a national baseline for care in that disease state. It can be done for any disease state. And so when you set that national baseline, then at least you have something to measure against. And until you have that, it's really hard to either reward or penalize people for behavior because you don't know what you're measuring against. And so that effort is, I know it's underway in other specialties, and certainly in my specialty it is, but that's a soft target in a lot of situations, and not all practices have the sophistication that we've been able to build. So I just tell you that the goalposts can be fuzzy, hard to measure against.
Yeah, and Paul, just to build on the measure piece, a lot of the things that may influence a disease are happening outside of the clinic walls and are happening with patients' behaviors. And currently, we're not really capturing that information in healthcare. We are making a big effort to capture more lifestyle-related factors through lifestyle assessments. But if you don't know what a patient's doing outside of the clinic walls, how can you even address what's causing worsening chronic conditions? So I think, including other measurements, and this could include both patient self-reported measure and also the measurements that are being taken from the amazing digital technologies that are out there, the wearables, and feeding that in and using it to make better decisions and support patient education about how their how their behaviors are influencing their health outcomes.
Any other questions? So maybe I'll just pick up on what Kaitlyn just said about wearables and digital health tools. Are any of you using innovative approaches to incentivize patients to use digital health tools in value-based payment models?
We are using them and we are subsidizing the costs for them when we can, when it's in our best interest to do so. But beyond that, we're not. So, and then, those are the sort of typical tools that you see. In particular, we have a strong focus on blood pressure. So, those remote cuffs that, so we subsidize that for our members in risk plans.
Yeah, we deal with a lot of fatty liver, obesity management in GI leads to significant chronic liver disease. And we have remote patient monitoring with digital scales. And we actually provide those to patients for free. If they'll simply get on those at least twice a month, although better if they can do it at least 16 readings a month, we can eventually recoup the cost of the scale. But that's the only real wearable digital device that's applicable in GI right now.
And from our members, I've heard, them using both the cuffs as well as the scales and RPM, but also the CGM to monitor blood glucose levels throughout the month. I think those have been really effective for some of our patients that are tracking diabetes-related disease.
We haven't to date. At some point, we probably will. I think for us, our view is that there's enough low-hanging fruit in other areas to find extra dollars or value to provide to members that are quicker wins, if you will, and higher value. So we're focusing more on those first, but at some point, likely we will get into the space.
Excellent, thank you. Committee members, if you have any other questions for our session participants, please flip your name tent up, or virtual committee members, please raise your hand on Zoom. If not, I'd like to thank all four of our experts for joining us today. You helped us cover a lot of ground in a short amount of time during the session, and you're welcome to stay and listen to as much of the meeting as you can. But at this time, we have a break until 1:05 p.m. Eastern Time. Please join us then for the public comment period and committee discussion. Thank you all again.
Thank you.
Thank you.
Produced by the U.S. Department of Health and Human Services.